Well, welcome everyone to the Youth Advocates Leading a Reimagined Mental Health System Centered on Equity and Justice. This is an early intervention plenary session. My name is Dr. Stuart Butler. I am the Regional Director of Behavioral Health and Addiction Medicine for Kaiser Permanente for Northern California, and I'm also a newly minted NAMI California board member, which is very exciting. We're very lucky to hear today to have three terrific presenters, Alex Briscoe, Jevon Wilkes, and Alejandra Gomez. And just a brief description of each of them. Alex Briscoe is the principal of California Children's Trust. Alex was appointed director of the Alameda County Health Services Agency in 2009, where he led one of the state's largest public health systems. And I have to tell you, I worked with Alex. He's very creative and thoughtful in terms of program development for youth. He has designed and administered several mental health and physical health programs and services in child serving systems, including home visiting programs for medically fragile children, and clinical and developmental programs in children's welfare, juvenile justice, and early childhood settings. Mr. Briscoe is a mental health practitioner specializing in adolescent services and youth development. He has specialized in Medicaid policy and administration, emergency medical services, youth voice and crisis counseling, and safety net design and administration. Jevon Wilkes is the executive director of California Coalition for Youth. For nearly 15 years, Jevon has dedicated his career to the nonprofit sector, focusing on disconnected, runaway, and homeless youth. Jevon's passion for serving youth comes from his own lived experience with homelessness, the foster care system, and being a disconnected youth himself. Today, Jevon serves as appointed member of the California Child Welfare Council, California Department of Health Care Services Behavioral Health Stakeholders Advisory Committee, and Proposition 64 Advisory Group. His appointments stem from his passion for addressing the needs of youth experiencing homelessness and youth service providers aligned with making youth homelessness rare, short-lived, and non-recurring. And finally, Alejandra Gomez is a youth specialist from the California Coalition for Youth. Alejandra is an Indigenous First Nations Ojibwe, Cree, former foster youth. Alejandra works for the California Coalition for Youth as a youth specialist, leading statewide youth advisory board and using their voice and lived experience to improve and empower the lives of California's youth through statewide, local, and national advocacy work. Alejandra has been instrumental in securing millions of dollars in funding, no easy task, to support current and former foster youth, juvenile justice involved youth, and youth experiencing homelessness so they may have the opportunity to reach their full potential and thrive. Alejandra aspires to use now as the moment to create much needed change that supports the social and emotional development of Californians, especially for California's most vulnerable populations. Alejandra is empowered to help and inspire others to make the world a better place for the generation of young leaders to come by first being the best example for themselves. So with that, I'm going to turn it over to our speakers. Thank you so much.
Good morning, everyone. Gosh, hearing my bio, I always think I'm like, it makes me a little bit ashamed. I feel like I'm like some kind of bureaucrat kind of guy. So thank you for those kind words, Stuart. I want to say to Jevon and Alejandra, it's such a pleasure and a privilege to work with you both and to be here today. So thanks for joining me. I'm going to provide some quick context for what is really an unprecedented moment in our state's history. But I want to suggest that if I spontaneously combust and you take nothing else from what I'm about to say, I hope you'll hear in my comments not only a respect for the wisdom and intelligence that Alejandra and Jevon are going to bring, but also that we are involved in a movement to reimagine mental health, not as a response to pathology, but as a support for healthy development in the context of social justice. Something that most children need access to, children and young adults, to understand a uniquely difficult time and a culture that is actually corrosive and dangerous to them. So I'm going to do a bunch of data and other stuff, but I hope you can hold that with me, that we're not talking about mental health in a traditional way, like diagnostic criteria. There's a place for that. I have literally billed hundreds of millions of dollars of mental health services. About 80 to 90% of the families I served were not mentally ill, though I had to give them a diagnosis to get paid. So stick with me. Alejandra and Jevon are awesome. You heard, thank you, Stuart, for those kind words and the introduction. We're going to cover some bad news, stuff that most of you know instinctually in your bodies and your minds and your hearts. But we're going to give you some data because it's important to go out, to go in, meaning we need to actually hold stuff that was happening before COVID, what COVID has done, and then basically understand what a unique opportunity that represents. And then we're going to talk about the good news. And how, if you really carefully listen to the experience and wisdom of young people and their allies, you can chart a course forward that can make it better for all of us. We're going to end with some questions and discussions. So first, data that I'm almost tired of presenting, but it's important to present because obviously each one of these numbers represents human suffering that is, the vast majority of it is needless. But the reason we show this data is that something was happening in the lives of young people that preceded COVID. So this is really important to hold. In the decade before COVID, we saw a 104% increase in admissions for self-injury. We saw a 50% increase in pediatric bed days. Young people were telling us through the California Healthy Kids Survey that they needed more. And unfortunately, California ranks 48th in the nation per Mental Health America and the Commonwealth Fund in independent separate analyses in access to needed mental health services for kids. So what's important to understand is there was a crisis in the lives of young people, and we could spend lots of time talking about why. Is it 400 years of structural inequality? Is it the availability of social media on mobile platforms in 2009? Is it a digital news and media cycle that is not developmentally appropriate? The answer is it's all of these things. But to think that it's the same as it ever was is wrong. Something is happening in the lives of young people, and it's not them. Key, right? It's not that we spiked Hetch and all of a sudden kids got pathological. It's culture. And so we have to adapt our systems of supports to acknowledge what is driving social and emotional dislocation in children. And COVID made it worse. ED visits increased, they got younger and younger, and we now know that 1 in 4 young people 18 to 24 actually seriously considered suicide. And when you put this in the context of the other data I gave you and look at the level 1 pediatric trauma centers, not only Children's Oakland, but also Rady's in San Diego, you see dramatic increases. Like, these are literally unheard of. And while they're presenting at the highest levels of acuity, they, of course, their origins are in the relationships and behaviors and the cultural messages we are giving. And in fact, when you now compare that crisis to what happened in mental health during COVID, meaning when you close schools, when you restrict access to clinical services, you get 34% fewer services that were provided, despite this increasing need. So we are now in whatever you call a crisis that you poured a bunch of gasoline on and lit on fire. Like, it pre-existed COVID, but it was exacerbated by COVID. And if you don't disaggregate this data by race and class, you're unknowingly contributing to bias. 81% of the 6 million children on Medicaid are Black or brown, they're non-white. Basically, there's 10 million kids in the state of California, almost 6 million are on Medicaid. The suicide rate for Black children is twice that of their white peers, and increasingly girls, younger and younger, are being victimized by self-injury and self-harm. Addressing disproportionality isn't just a matter of tweaking programs and fixing Medicaid reimbursement, though that needs to happen too. It's a matter of acknowledging the impact of race and class on the social and emotional welfare of children and young adults. As I mentioned, healthcare access has decreased. When you disconnect young people from the supports that they receive formally and informally, we've now seen what happens. 20% of California cited COVID as a driver of their delay in care. The disproportionality, of course, was exacerbated. 1 in 3, 1 in 4 people making less than 250% of federal poverty lost their jobs. We know that economic dislocation is tied to social and emotional welfare. COVID has basically exacerbated these emerging tensions and forced us into a reckoning around social and emotional health of children. If you weren't listening to us 3 years ago when the trust started, when we said, hey, something's going on in the lives of kids, you are now, right? It's happening. And the medical model can't be the answer. Not only is it a mathematical question, meaning children 8 to 18, where 75% of mental illness manifests, simply go to the doctor the least. They have the lowest rate of primary care utilization. So the traditional kind of send someone to the primary care provider, have them refer out, doesn't work just from a supply and demand perspective, but it also doesn't work from a cultural perspective. We know that if you want to kill volumes in an adolescent health clinic, put police or parents in the waiting room. Eric Erickson called it individuation, but young people are growing up and out of their primary care group, and understanding that reality and building services and supports that they can access and want to access. What we say in my field is that all therapeutic gain presupposes therapeutic alliance. It doesn't matter how good a therapist you are if young people don't want to talk to you. Diagnosis-driven models, while appropriate for some children, aren't appropriate for the vast majority of children. How did we get here? We don't have a common framework for understanding behavioral health between public systems and clinical care providers. Like, it's part of everything, but not defined. Our systems are deeply fragmented. We have a lack of clarity whether this is a public health benefit or an essential benefit. It's obviously both. And our definition of medical necessity is clearly outdated, meaning you don't have to have measles, mumps, or rubella to get a vaccination. Why do you have to have a diagnosis to get access to support? The good news is stigma is reducing. I mean, too bad we had to have a COVID for us to understand that, yeah, our context does impact our social and emotional health. Since the pandemic began, we are seeing evidence that mental health problems have become more common, but our public perception is also changing. And young people, it's already changing. Like, young people are far more comfortable talking about their social and emotional welfare than adults are talking to them about it. And that's a little bit of a challenge we have to acknowledge, that the clinical system is so far behind the reality and experience of young people that we have to do a much better job. And that's what we're here to talk about today. Finally, COVID has been an equalizer, certainly not an impact, but it has led us to understand the universal trauma that everyone in our culture has experienced. And we should acknowledge the work of Dr. Nadine Burke-Harris, our extraordinary Surgeon General, who's also helping us understand and accept that the impact of adversity in childhood has long-term health outcome realities that we must design and engineer for. Some good news: telehealth has brought greater access. We've learned some really important lessons that, texting and access to digitally enabled modalities are super important to young people. Young people tell us so. Look at the quotes on the bottom. And a recent national study has found that 70% of behavioral health providers plan to move to this modality or continue to use it as an important extension tool. The story I'd like to tell here is a clinical practice that I used to work in. The very first weeks of COVID, started texting all of their young people on a Tuesday morning at 7:45 in the morning. A clinician texted a young person who usually have waited to see weekly. That young person was in a dark place, decided, was self-harming. 911 was able to be called. That young person's life was saved. If we start thinking more about relational connectivity and not as much about length of session, we can develop new tools, and technology is an important part of that. Finally, we're involved in a lot of discussion around the use of technology, in particular texting. And this is the point I was trying to make in my last comments, that I remember working in public schools in Oakland, where I would say what's up to a young person for 4 or 5 years in a row and find out at the end of 5 years that they were sleeping in a car and really needed support. We don't get to schedule the availability of young people. They get to choose. And texting and short interactions that are non-instrumental, that are, like, I'm here, I care about you, they are an essential part of our clinical practice, but have not been reimbursed or structured, and must be. There are new opportunities if we are courageous enough to redesign our system to embrace them. Jevon, I'm going to pass it off to you here.
Good morning, everyone, and thank you so much, Alex. Can you see the screen? So at the moment, CCY and CCT has really put a lot of efforts and what I would say heart and true determination to really change the trajectory of how the state really seeks to support our young people. And so the last time we met, we brought up some data that we were going into, and today we want to share that data. And so we want to share the data and lift up the voices of young people and reach your mind, your heart, especially as it pertains to the policy changes and the policy and the systematic shifts that we are currently going to have to endure and move through. So at this time, I want to hand it over to Alejandra for you to go ahead and hear from them. So Alejandra, please take it away.
Thanks, Jevon and Alex. I really appreciate you guys letting me be here and discussing more about what we need to do for youth. So next slide. Thank you. So for the youth survey background, in September 2020, unaccompanied youth across the state of California were invited to take a survey on how COVID-19 pandemic had impacted their lives. The results show how their path to stability had been further complicated by the pandemic and amplified the unique needs that these youth need. It is important that we invest in youth-focused solutions to meet their needs in an efficient and effective manner. Next slide. So about the survey response, about 32% of youth had 3 or more different sleeping locations in the last 3 weeks because they could not stay in their home and did not have a home. California has the largest population in unaccompanied youth experiencing homelessness on a single night of January 2019. The pandemic has intensified the instability, and we project a significant increase in this population as more youth experience homelessness than ever before. Next slide. So access to food, water, bathroom, and housing and technology are basic resources and basic needs for these youth. In today's time, we need more mental health resources in school, peers, and mentors in community-based organizations. When youth have these essentials and resources, they're positioned to succeed and thrive. Compounded by trauma without the resources that they need is a recipe for disaster. And so we have the youth voices. And the COVID-19 pandemic has disrupted the already fragile lives of homeless young people. The changes of employment and further income make it complicated. And so we have it right here where from some youth, it says that COVID has affected my life by leaving me jobless and unstable to provide for myself and leaving me with no choice but to look for a homeless shelter. Me being a former foster youth and experiencing my own disruptions of the COVID pandemic and what it was to switch from different housing, it was really frustrating for me as well. And this is why we need to really focus on these youth, and we need to focus on, giving them more resources, because our youth are the first priority. If we want to prevent homelessness, then we need to start with youth at the beginning, because they're the ones that are going to be experiencing that when they're older. Next slide. And then Jevon, you can take that over.
Thank you so much, Alejandra. And I just want to kind of go back to the slide where you get to see the youth voice. These are real young people. And as Alex has spoke to, as Alejandra has spoke to, as we are here to speak to, our young people are needing us to step up for them before the pandemic. And now that we have endured such a long, tumultuous time in this pandemic, we know that we have work to do. And right now we have an unprecedented time to really support our young people's ability to thrive by meeting their social and emotional development needs. And so as we move through starting that process through policy, Cal AIM was one of the huge drivers of really bringing forth change and making sure that there's a removal of diagnosis and resist pathologizing the adversity, the hardships that our young people have had to endure. And we'll go into how youth stepped into this work to really bring voice so that their stories are told, so that they literally stand in front of all of that is to endure for their peers, for the children to come. We've worked on increasing school mental health support because we know that it starts in a place that is mandatory for young people to go. And yet we have to make sure that there's services and supportive services to meet their social and emotional development. It's the person before the content. And that person is the person to understand the content and move into the positions that we need to serve. And then, of course, we're working on making sure that we reinvent the system, make it better, holding MCOs and low-income organizations that are there to serve, holding them accountable to the work. And so right now, again, we have an unprecedented time, unprecedented money available, and we have the opportunity to bring young people into the fold to make sure that they are also not just beneficiaries, but also influencer and impactors of the work that we have ahead of us. And so these unprecedented investments is all to really make sure that we elevate the social and emotional and mental health of our young people, and we want to make sure that is driven by youth. So we have $4.4 billion in the youth behavioral health initiatives, and you can see there's hundreds of millions of dollars going into different pots of opportunity. The government budget of California, over $15 billion of investments. And of course, from the federal stimulus, we have unprecedented opportunity at a historical level to step in, but we are not going to be able to just do it with the money alone. We need the hearts, the soul, the minds of not only the professionals who have been in this field, but the young people who have to endure, and the young people who have the minds and the intellect and the wisdom to help get us to the level in which we'll meet their needs even more crucially. And so we really take this on through making sure that we look at it through an equity and justice lens so that we can transform what needs to be transformed for our young people. We bring them to the table. CCT and CCY has been working together to elevate the youth voice because they are the future now and tomorrow, because guess what? We have neglected so many of them yesterday. We have that moment now, and we need to step into that light because of the fact that we have worked so hard to make sure that we're expanding access and participation. Youth are coming to the table to say, diagnosis, what diagnosis? I have gone through adversity. I have seen death and suffering and endured traumatic experience from physical, mental, sexual abuse. And these are things that are above a diagnosis. And we need the support to make that happen. And so we have brought young people to the table so that they can bring their voice to push forward these policies. And we did that through the CalAIM 1915B waiver. We have seek opportunities that I've discussed, the many levels of funding that is billions of dollars that are becoming available to make sure that schools are placed to be centers of healing so that young people can thrive, so that young people can engage in the opportunities to also support through peer-to-peer supportive programs to get their peers the support that they need by coming together with the young people, with their peers, with the administrators, with community, to make sure that we are building a system that is going to work, because right now is the time. And so youth leaders have been increasing school mental health awareness across the state. We're doing this with them because they are, again, wise and very intellectually sound in knowing what the times are and the best ways to reach them and support them to thrive. And of course, all of this is to reinvent the system. You've heard from Alejandra having lived experience in navigating the system. And I stand today as someone impacting the navigation of the system so that young people at least have an open door that gets them to the next level, especially as it pertains to the relationships of the places in which they are sent. So reinventing the system starts from MCOs and making sure that they are prepared, and young people are bringing their voice to make sure Alejandra, Levi have come to the table to make sure that their voices are being heard, because it's not just their voice. They are also bringing forth their peers that they are talking with and communicating with, and unfortunately having to watch them suffer, and they want their peers' lives to be better. And so we're shifting the way that things are being done. It's not a time for business as usual, because COVID-19 was something that was unexpected, and we had to fight to get to where we are today. And so in order for us to get to tomorrow, we have to fight to make sure that our young people have the best opportunities to thrive in community, especially in our state of California. So with that, I'd love to turn it over to Alex to go ahead and open us up to really thinking about how we move forward, think about questions that's going to support this drive that we have, this movement at the moment in this historical time. So Alex, please go ahead, take it, brother.
Thank you, Jevon. I can't help but reflect like all of the work that Jevon and Alejandra and Levi have, and many others, young people have done. It has been in some ways part of our challenge and burden, delightfully carried, to help make plain some pretty complex stuff. So I once had a mentor who said to me, we have the most complicated descriptions for the things we understand the least. And that's a great way to describe California's really complex system. Like there's a reason we're 48th, right? And it's not because we're bad people. And it's certainly not because of our tax base, because we have the 4th highest tax base in the nation. So something's going on, right? Like we haven't figured out how to do this stuff, right? But now there's money. So some questions for us to begin to engage on, because it is important to acknowledge that while there's tons of money, it was largely poured into existing structures and buckets. Like we did not in any fundamental way reimagine how systems work with each other. We threw a bunch of money at this problem. And so while that's welcome, the Buddhists say the truth will be in the unfolding. So some questions for us to begin the Q&A is what we're talking about now is almost all promise and not practice. So a legitimate question for many people to ask is, how will this roll out? How will it be made different than it is today? Then we have a really important question for us. You've heard it multiple times today. We have said that an important symbolic shift of our medical model is the removal of diagnosis as a prerequisite for entry. And so that's obviously not the whole answer, because it's part of a no wrong door, meaning wherever young people present, do they get what they need? And who will serve them? The essential strategy for equity and justice, and this phrase was gifted to us by the amazing Dr. Rhea Boyd, is will we have the will and courage to shift agency and power in our mental health system? Agency as defined by who does the work, and power as defined by who gets paid. So again, while it's more promise than practice, the governor's reform proposals include 4 new provider classes: doulas, CHWs, behavioral health coaches in schools, and certified peer mental health counselors. We are at the dawn of maybe the first time, at least in my career, where we could legitimately project between 5,000 and 10,000 folks who look like people in Medicaid could get a job serving the Medicaid population. Do we have the will and the skill to capitalize on that opportunity and shift how young people access care and who gets paid to do it with them? What will it take to center schools? It's going to be messy. We're in the heart of a lot of these conversations. And it's, all I can say is it's going to be difficult. Systems change isn't clean and easy. People have to check their histories, their pride. There's a lot of people stomping their feet saying, I know how to do this. And if we can all humble ourselves, we don't know how to address the toxic environment that young people are being raised in this culture. We have not figured out how to address 400 years of structural inequality as a culture or as allies for young people. So we have to walk humbly into this work, and particularly in the bridging and nexus of public health and public education. So the bottom line, will children and youth families be better off? That's the question we all have to ask. Like, I know lots of people who are on this webinar today have been screaming into the wind for decades about the needs of children. So thank you all for being part of a movement that is starting to pay off. And no one gets credit for it. Everybody did it. We've all been saying something's going on. And it's not them crazy kids, it's us. And so how will we measure if we're better off? Well, yes, we should see lower rates of self-injury and ER utilization and depression, but there has to be new measures. New measures that young people like Alejandra say, this is working for me. When will we have the courage and wisdom to ask young people in Medicaid if they're getting what they need? Meaning, how will we develop new evaluation and outcome measures that are more culturally concordant and more youth-driven? Unfortunately, that conversation is not part of the narrative of these reforms. We're still talking about where the billions will go. So with that, we'll open it up into the Q&A for questions, and I think we have a facilitator.
Thank you so much, Alex, Jevon, and Alejandra. Just a few summary notes related to the wonderful talk we've just heard is that Alex pointed out that that even before the pandemic, we were seeing rising rates of youth who were having great difficulty accessing care and also being significantly disturbed. Pediatric days he mentioned, and poor access to care for kids, both in mental health as well as primary pediatrics as well. He pointed out that telehealth and access and texting has been important in meeting kids where they are. Alejandra pointed out that we've done a survey on the pandemic. It's complicated, that about a third of the youth have had their lives even more disrupted. They're going from house to house and being even more homeless that's not being addressed, that we have to really look at the basic needs in life, which are food, water, housing. How are we handling that? And the instability of life has created a lot of trauma. Jevon really did a wonderful job of talking about the financial situation, that the opportunity that we have. He mentioned, I added it up, about $45 billion is available for us to change the system, and that equity and justice has to be at the core of it. And then Alex talked about not needing to have a diagnosis for people to get the care that they need, that there's no wrong door, that schools need to be places of healing and well-being, and that we need new measures to actually see that we're approaching our goals. So in brief, those are some of the key ideas that I gleaned from the speakers today. And we're now opening up the floor and taking a few questions. Lori Kapp is going to be reading questions and looking at the chat as well. I also want to remind everybody to honor the community agreements we went over at the beginning of the session as we open the floor for questions. If we do not get to your question, we may collect them and answer in a follow-up email. So go ahead, Lori.
Hi, thank you very much. A couple of questions that have come in, and I think this one, maybe Alex, you have a response to, but one of the questions was, is there a strategic plan being developed? I think what this is probably referencing to Stuart's point and others' points to kind of leverage all of these new dollars and new potential. And then secondarily, is there a model in another state that is, providing this kind of what we would call, a behavioral health system for youth that is centered on equity and justice and sort of meets that framework for solutions? So 2 points, like, is there a mega strategy, and is there any other state that's doing it well?
Yeah, thank you, Lori. And I don't know, Jevon, if you could just click up so we could see the framework for solutions, that would help for my comments to respond to this. So the answer is no. That one's fine. Great. Thanks, John. There is not an overriding strategy. I think it's fair to say, and I don't say this in any way to demean or diminish Secretary Galley. I think he's the most extraordinary leader we've had at the state in forever. So I very much believe that the Youth Behavioral Health Initiative is meant to be a galvanizing strategy, but it is not yet effectively articulated to CalAIM or the education reform like the Community Schools Act and like expanded learning opportunity. So in many ways, I see that as our job, everybody here. Like, we need to take the promise and turn it into practice. So what we've tried to do at the Trust is provide a framework for allies and advocates, system leaders, and state leaders to hold these various components and determine if they're moving us in the right direction. And that's what you're looking at, this triangle here. We say that we will know our system is making progress when it brings in more money, when it expands access participation, and it reinvents systems. But all of those things must be focused on equity and justice. And I don't use those words loosely. Equity and justice means our primary strategy for equity and justice is the shifting of agency and power, the shifting of who does the work and who gets paid to do it. So the answer directly to your question is no. It's a legitimate question. It's the right question. We do not have an overarching strategy that links together these three primary new investments, right? They are the Youth Behavioral Health Initiative, CalAIM, and the school money. You could put the federal money as a fourth bucket, but all four are not yet cleanly and clearly articulated to each other, though they're all welcome in their own right. We're trying to provide from afar as advocates a framework and structure to understand all four, to move them towards a more cohesive vision. The second question was, is there a state that's doing this right? And the answer is no. There are states that are doing good things, including Connecticut and Massachusetts, who have models of integrating managed care and essential benefits with public subsidy to create a universal program. Like the crisis response program in Massachusetts is good. Some of the placement work that happens in Connecticut for kids with special needs is good. But, frankly, in California, we want to go from last to first. We think that the reforms that other states have done, as impressive as some of them are, and there's lots to be learned from them, none of them directly and specifically center the experience of race and class on the social and emotional health of children. And we want to kind of be the first state to do that. And there's things happening. As a very specific example, the new family therapy benefit that was just approved in June of last year, for the very first time, allows for reimbursement for mental health professionals based on an experience of racial discrimination, based on housing instability, or any of the 10 other traditional adverse childhood experiences. We all need a t-shirt that says Z65.9. Z65.9 is the code that allows clinicians to directly bill for services and supports tied to these experiences of adversity, including racial discrimination and an experience of housing instability. Rethinking and tying our reimbursement systems to these new and reimagined ideas are essential to measuring progress.
Alex, another question that came in, and I'm going to expand it a little bit, but how does California's workforce in terms of number of behavioral health providers compare with other states? Or is that another area where we're behind? And I'm going to add to that, because when we're talking about behavioral health providers, one of the things that has come up repeatedly in lots of discussions is, and do those behavioral health providers look like, understand, and truly meet the needs of the affected populations that we're talking about?
Yeah. So direct answer is, we, by number of clinicians per zip code, we're about average. But number of clinicians per zip code who take Medicaid, below average. And percentage of clinicians who reflect the cultural diversity of the state, we suck. I don't know how to say that in any other better way, but that's not a California thing. That's a national thing. The vast majority of the professional mental health workforce doesn't look like the kids in Medicaid in California. So that's not anybody's fault. It just is what it is. And I would say that the workforce issues have been well documented by the California Healthcare Foundation and many others. The key thing to hold about the workforce issue is there is no way to get there from here, meaning we call this in the healthcare space empanelment, but or how many patients or clients should a clinician be able to serve at a time or in a year? And you can't get there. There's just simply, we're not training enough. There never will be enough licensed therapists, and nor should there be. We have to reorganize our mental health workforce so that the young people with who meet traditional mental health challenges, of which they exist, right? But they're somewhere between 5 and 10% of the population. That's where our clinicians need to be focused their energy on. We need a new workforce that's clinically articulated, but not necessarily imprisoned in the medical model. And I think that opportunity, that change is coming. I think you will see more team-based mental health services where a clinician and a care coordinator and a behavioral health coach will be working together, but not every service is a traditional mental health service. So I think that answered your question, both questions, Lori.
Okay, terrific. Well, I believe we're coming to an end. Jevon has just shared our last slide with everyone. And I guess bottom line is we'd really encourage all of you on this. There's 38 of you on this in this workshop. If you can support all of the statewide advocacy efforts that we've been describing, we have a terrific number of policy briefs on our website. And by signing up for both the CCY and the CCT newsletter, you can stay engaged because we need all of your voices. So I will stop there and encourage Alex or Alejandra or Jevon, if you have any last words.
I have to step in. I'm so sorry. We don't have any more time left. Thank you all for joining today. And thank you so much, Alejandra, Jevon, and Alex, for your wonderful discussion. For any questions on the content, please feel free to email the presenters. For any questions or concerns for today's event, please feel free to email namica.org. You're welcome to leave the session to move on to the next part of the program. We invite you to take the evaluation survey that will be sent out to the end of the conference. Your feedback will be greatly helpful for our next conference. Please remember to take some time and breaks for self-care. See you in the next session. Thank you all. Bye-bye.